Good afternoon, everybody, and welcome to the August edition of the SEAL Healthy Longevity webinar series. My name is Jocelyn Protopappas, and I'm the Manager of Special Projects at San Diego State University's Center for Excellence in Aging and Longevity, or SEAL. Today's topic centers around something that is critically important to the health, well-being, and longevity of older adults. I bet you can guess what it is based on the title slide here, but the topic today is around access to behavioral health for older adults. Older adults can face a unique set of challenges when it comes to mental health and well-being, including issues with loneliness and social isolation, loss and chronic grief, and also some shifts in cognitions for some older adults. Having access to supports and services can serve as a lifeline for these folks. Today, we will explore these barriers and challenges in more detail. We will also discuss what access really means when it comes to behavioral health. I am very excited about our speaker today. Today, we have with us Amanda Berry. She's a seasoned public health and policy professional currently serving as, drumroll please, Amanda just got a promotion, as the Director of Managed Care Advocacy at the Health Centers Partners of Southern California. HCP is a regional consortium of community health centers across San Diego, Riverside, and Imperial counties. With a career rooted in advancing access to high-quality healthcare, Amanda brings deep expertise in behavioral health systems, policy, advocacy, and cross-sector collaboration. She served as the senior policy advisor to San Diego County Supervisor Tara Lawson Reamer, where she led health initiatives in health and human services and public safety. Amanda also contributed to statewide behavioral health policy reform through her work at UC Davis, where she translated research into policy and community solution. Amanda holds a master's degree in social work and public health from SDSU and a BS in biopsychology from UC Santa Barbara. She is an appointed member of the County of San Diego's Behavioral Health Advisory Board, where she helps shape local behavioral health policy and community engagement strategies. As you can see from all of those accolades, we are in the right place with the right person to be talking about behavioral health access. So without further ado, Amanda, I'm going to pass the mic over to you.
Thank you so much, Jocelyn, and thank you to SEAL for having me today to give this presentation about behavioral health access for older adults. It's something that's near and dear to my heart, and I look forward to this conversation today and to kind of walk through what are some of the really big pressing issues and hopefully some hope and optimism for the future. I know there's a chat and there's a Q&A. I love questions and engagement throughout the time, so feel free to introduce yourself in the chat, put your questions in the Q&A. Love to know who's in the room. It sounds like we've got quite a diverse audience today, so thanks all for having me. Let's see here. Before I get started, Jocelyn shared my bio about all the things. I want to kind of ground us in the lens that I bring today. My lens is rooted in a background that's really interested in policy and how do we change really the systems that create the environment for people to thrive. I am currently at Health Center Partners of Southern California. And again, we're a regional consortia. So we have 17 member organizations, including federally qualified health centers, Indian health centers, and Planned Parenthood of the Pacific Southwest. You may recognize some of the names on the logos, folks like True Care, San Ysidro Health, Father Joe's Villages that provide care to almost 800,000 patients every year. And we have 210 practice sites through our members across the San Diego, Riverside, and Imperial County region. So really my lens is grounded in the federally qualified health center space and primarily for folks who are on Medi-Cal or are dual eligible for Medi-Cal and Medicare. So that's the lens that I bring and my expertise so that you all know that's kind of what I'm speaking to when I'm talking today. Okay, so many of you I'm sure have been very familiar with this really big boom that we're having and the demographic shift in our population in California, that we are having more and more older adults in California as the population ages and our population is becoming more diverse, that there is actually no race or ethnic group that's going to have a complete majority in 2040. Okay, so we have a really growing older adult population. We have a more diverse older adult population. And half of all Americans will have experienced a diagnosable behavioral health disorder by the age of 75. So a lot of people are having a diagnosable behavioral health disorder at some point in their life. And yet, less than a third of those older adults who are in need of mental health care receive the appropriate care. They're not accessing care. And so we say, okay, well, why aren't people accessing care? So for mental health, and when we talk about behavioral health, we're talking about mental health and substance use disorders. We're seeing a really large push through Proposition 1 in California towards really integrating behavioral health with primary care. And we're also seeing a lot of understanding of mental health and substance use disorder. So 12.7 million older adults received mental health treatment in the last year. And of the older adults who did not receive treatment, 95% did not think that they needed it. So of that pie chart of folks who didn't receive care, they didn't think they needed it. The same sort of thing, 97% didn't think they needed it for folks who needed substance use disorder treatment. So we say, okay, there's a lot of folks, a lot of older adults who need mental health care, but they're not receiving treatment and they're maybe not even realizing that they need it or they don't want it. And so we say, okay, why is that? It's one of the most powerful invisible barriers is one of the components of that, and that's stigma. Stigma will often silence folks who are in need. It's really an internal and an external component. And folks will internalize the idea that seeking care is a weakness, that you hear these common things like it's just part of aging or therapy is for people who are weak. Really common, I don't want to be a burden, or I just got to suck it up, got to soldier on, pull myself up by my bootstraps. There's some fear, particularly for older adults, of being labeled or being institutionalized. Say, oh, if I go and seek care, then maybe I'll lose some of my independence. There's cultural stigma. Different cultures have different stigma about behavioral health and behavioral wellness. I'm sure many of you are aware that the differences in kind of the openness to talk about mental health and well-being for different generations. A lot of older adults were not raised in a time where you talked about your behavioral health conditions, where it was acceptable to seek care or find a therapist. Um, and I want to say it's often intertwined with grief and isolation. So when someone loses their friends or their partner or components of their independence, it can compound those feelings of loneliness for especially for older adults. And so what one of these kind of compounding factors for stigma is the idea of social isolation. Because of stigma, continuing to isolate oneself and becoming more lonely. So back in 2023, the US Surgeon General came out with this really transformative report. It's one of my favorite reads if you need a good read, on our epidemic of loneliness and isolation. And this epidemic of loneliness and isolation, they have this really interesting vital components of social connection, structure, function, and quality. And you think about, okay, what are some of the things that might contribute to someone's loneliness and their isolation? A lot of it has to do with the structure. So, the number and variety of relationships and frequency of those interactions, which is oftentimes determined by household size. And how many are you living in a multi generational household? Do you have a lot of kids or grandkids? How many friends do you have? What does your social circle look like? Are you still having a social circle maybe after you've retired and you no longer have daily communication with others that you might consider your colleagues or your friends? Changes in marital or partnership status, whether or not you have a partner who is still with you, or what your living situation looks like. And you see these kind of structural changes um, happen in really large ways for folks as they get older. You could have a death of a spouse, change your living arrangements, whether you're, kind of downsizing the space that you live in, or you're moving in with loved ones. The chronic pain and deteriorating physical health. We know that physical health and mental health are inextricably linked, and I'll talk about that in a minute. But um, having chronic pain or changes in your physical health or your ability to do social activities or active activities can impact your feeling of connectedness and your social circle. So some of these losses and changes in life, whether it be with mobility, or whether you're in a nursing home or something like that, can really impact someone's mental well-being. And I think it's important, to that stigma point of looking at the changes in environment and situations can potentially spur a mental health condition. And it can be a temporary depression, or it can be something that leads to a diagnosable condition. Okay. Social connection and its influence in health. And you're like, okay, you're talking about having friends, being socially connected, but what does that have to do with my physical health? From the Surgeon General's report, 50% chronic loneliness and isolation can increase the risk of developing dementia by approximately 50% in older adults. Again, chronic loneliness and isolation increases risk for dementia by 50%. They also show increases in hypertension and diabetes and other physical health conditions that come out of social connection. And, there's the biology, the psychology, the behaviors, all these things are impacted by social connection. The one that stands out to me, and maybe is a call to action for all of you, is to really think about the meaning and the purpose, the stress, safety, resilience, hopefulness. These are things that don't necessarily happen in the clinical environment of seeking therapy, seeing a psychiatrist, talking to your primary care doctor about your behavioral health, but they're all the things that happen outside of the doctor's office. It's like we say, going to a personal trainer. You go to a personal trainer once, and that doesn't necessarily mean that you're going to be this great, healthy, or able to lift weights and everything. It's the exercise that you do on a day-to-day basis that's going to keep you healthy. The same thing is true for your mental well-being and your behavioral health. It is a practice, and there's all of the social environment things that impact your ability to be well and to be able to either navigate a diagnosed mental illness or substance use disorder, or to preserve your mental well-being writ large. Okay. I love a survey. I hate taking them, but I love the results when they come out. And this survey results, they just came out very recently from the Insure the Uninsured project, working with the state of California on the behavioral health of older adults. And social isolation and loneliness, number one primary behavioral health challenge. Not surprising. Not surprising. The other top challenges were cognitive decline and dementia, caregiver stress and burnout. And they also talked about financial barriers and transportation access, which I think is really important to think about as your financial stability, maybe have fixed income, things like that change over time. And then they mapped the top 3 significant service gaps. And I'll talk about this when I really dive into access. The lack of behavioral health services targeting older adults. Do we have services that are appropriate and targeted for older adults, or is it all one size fits all? We know it's not, and it shouldn't be. So, how do we encourage investment in care that is targeted for older adults? We've got a fragmented delivery system. Tell anybody trying to navigate anything in healthcare, for yourself, your family member. Um, Care coordination is absolutely key. And I will highlight some things that Health Center Partners and Integrated Health Partners, one of our companies in the family of companies, is doing to improve care coordination in California for our patients. And then really lack of awareness of what are the issues? What's going on? And I think that's one of those things where it's a call to action for all of you to elevate the issues that older adults are experiencing, ones that are unique and ones that are not unique, that can be joined in coalition to fight to address, to improve our system of care, because we know it is fragmented, it is confusing, it's challenging. So we kind of have to work in coordination with others and elevate those voice of older adults. Okay, so I said I was going to talk about access and what access really means. So I have this question for you. When I say, do you have access to healthcare? If you have insurance, do you really have access? If you have that card in your wallet or on your mobile phone or whatever it might be, that you have Medicare, do you have access to behavioral health care? A lot of that depends. It depends on the network. It depends on the providers. It depends on the system and its willingness to serve older adults and kind of bust through that stigma. It depends on whether or not it's going to be integrated into your primary care setting, whether or not you have access right away. And just because you have that card doesn't necessarily mean that you can afford it. I think that cost can still be a barrier for many in terms of seeking care and wanting to actually get help with behavioral health needs. Okay, so maybe having an insurance card doesn't mean that you have access to care. It's one component of it, but it doesn't necessarily mean that you have access. Um, and when we talk about access, we're talking about all of the different settings. So once you have the insurance card, once you have coverage, you have the financial means, that's the first step. But you have to ensure that you're getting the right care in the right place, the right time, by the right provider. And I put in this image for all of you to look at the county behavioral health care continuum. Again, I sit on the county's behavioral health advisory board, which is a stakeholder group informing the county of San Diego how to pursue behavioral health in our region and improve it for our communities. And it's complicated. There are a lot of different service categories, a lot of different places where you can get behavioral health care based on what you need individually, anywhere from your primary prevention services, you're getting all of the social needs that you need met, all these upstream drivers, you're getting outpatient care, you're getting therapy, you're getting seen by a psychiatrist. Crisis care, what happens when you're in crisis? When you feel like you're going to be a harm to yourself and you need crisis care immediately. What does that look like in terms of getting access there? What does it look like when you go into the hospital and you're being seen for a physical illness or a physical condition? And do they take into consideration the behavioral health needs that you might have? What's going on with you mentally. Um, and then long-term care services. What does it look like for board and care services, for skilled nursing facilities, and things like that? So just because you have an insurance card, just because you might know where you want to get care, that doesn't necessarily mean you have access. What if you can't get there? Transportation is a huge issue. And it was even ranked on one of the top things from ITUP of how does somebody actually get to their appointments? We've got MTS, we've got bus, we've got people driving themselves, we've got loved ones driving themselves. But again, access involves many more components than just having an insurance card, just having a way to get to the doctor's office. And then that last slide, I had a picture of a PACE van, and you may have seen these driving around town. There's a few different PACE organizations. Health Center Partners has members, San Ysidro Health and Neighborhood Health that have, and True Care that have PACE programs. Those are program all-inclusive care for the elderly. So if you've seen one of those vans, you're like, what is that? What is PACE? It's a program for adults who are age 55 and older, able to live independently in your home, but you're dealing with some chronic conditions that require a higher level of coordinated care. So when you are part of a PACE program, you get all of your primary care, you get dental, prescription medications, transportation, and social services. There's a few different eligibility requirements that you have to meet in order to be part of a PACE program, depending on where you live, and depending on your insurance type, depends on your payment needs. Um, but it's a very wonderful program that really incentivizes good care, both through the way that it's paid in its payment model and in the way that it's designed because it's integrated for primary care and behavioral health. And going back to that note about stigma, having integrated care where your primary care and your behavioral health care are in the same place at the same time, that they're coordinated, they're part of the same system, can really reduce that stigma of, oh, I don't need to go to therapy, or I'm just going to soldier on and get through it. By having behavioral health integrated with primary care, it kind of lowers that bar, say, oh, this is just part of my healthcare because mental health is health. Okay, so you say, okay, you've got access for transportation, insurance. What about getting in to see a provider? If you have a provider that you know, um, is that access to you? What does that mean? Um, One of the things that and I want to talk about here in particular about provider availability is the availability of trained providers who are trained in serving older adults. So just because you have access to a primary care doctor, and you can't see a raise of hands, but I'm sure many of you have been to a provider that you're like, well, I don't really jive with them. I don't get along with them, or they don't know my needs. Um, but having access to a trained provider that knows how to serve older adults, is trained in geriatrics, is actually not as common as you would think. According to the American Association of Geriatric Psychiatry, there are fewer than 1,800 geriatric psychiatrists in the entire United States. Less than 1,800 in the entire US, and that's psychiatrists. So those are the folks that generally do prescription medications. For nurses, what kind of training do you think that they get or specialization that they have in geriatrics? It's about 1%. Psychologists, 4%. Social workers, and I'm a trained social worker, not a clinician, macro social worker, but I'm a social worker, 4% training in geriatrics. And only 3% of medical students are taking geriatrics electives. So when we think about how do we actually improve access to care, and we're talking about access to behavioral health care for older adults, that means we need to train our workforce to be ready to serve older adults, to understand some of the unique challenges that they have, understand how to work with family members and caregivers. And That's something that we need to invest in larger on a larger scale at the state and federal level in terms of how we actually train and invest in our workforce. Okay, so all of you, I ask you to think about what access to care looks like for you. Is it that you have a trained provider that is culturally competent, that speaks your language? Um, do you have the type of support that you need, whether or not that's a specialization in a particular diagnosis, a specialization in dementia or schizophrenia or anxiety disorders or PTSD or grief, whatever it might be? What does that access to care look like in terms of the training of the provider? What does it look like in terms of the place of service where you're getting your care? Are you doing therapy at home via telehealth? Because that's what works best for you. And that's a way for you to be consistent in getting the care that you need. Do you even have the technology that you need in order to access the telehealth appointment and call in and talk to a provider on, is it an iPad? Is it a phone? Do you have the technology education to know how to navigate that system? I was on trying to FaceTime with my mom the other day, and it was not going well because she has an Android and I have an iPhone, and we all, all these things. And it was frustrating. And going into a therapy appointment where you're trying to work on your behavioral health, and maybe you're already experiencing some anxiety or you're working through an anxiety disorder, and then you have a frustrating experience with the interface, that could lead to a poor experience as a patient. Or you have a great experience and you're like, this is what works for me. This means access to me because I was able to do it from my home with the technology that I have, and I understood it, and I have this relationship with a provider who gets me, who speaks my language, who understands the unique needs that I have. And when you have access, what does it feel like? Does it feel like you're not being a burden? It dismantles all of those kind of stigma things that we talked about where you don't have stigma. You don't feel like you're a burden. You feel like you're caring for yourself just like you would care for your physical health. You're also caring for your mental health and your well being. So think about that for yourselves. What does access to care actually look like? Does it look like having an insurance card, transportation, culturally competent, trained care? And what does it mean for those of you who maybe work in government or work in nonprofits to think about how do we create this puzzle piece, all of the puzzle pieces that improve access to care and put them together? Because just one of those pieces, just having insurance, isn't enough for true access to high quality care. Okay, I'm gonna call out something that the state and the federal government has been doing in terms of crisis care and behavioral health. And as we think about what does access mean, it means across the entire time frame that you need care. For 988, we call that someone to call. So for those of you who aren't aware, 988 is the crisis call line. It used to be the access and crisis line. It still goes to the access and crisis line. So when you call 988, you get a trained clinician to be able to pick up the phone. And it's an alternative to 911 when you're experiencing a mental health or behavioral health crisis. So instead of calling 911 and having all of the sirens go off and the ambulance and all of the things that might be more traumatizing to someone, you can call 988 and that's someone to call. And then if you need someone to come, the mobile crisis response teams throughout the county will come and they have trained providers on them. They come in their vans and it's more calm than when if you call 911. You can still call 911. Please think you can because you can. But 988 is a specific for behavioral health. And then say you need somewhere to go. That's why the county is investing in crisis stabilization units and other alternative treatment sites so that you don't have to end up going to the emergency department or somewhere else if you're having a behavioral health crisis. Our crisis stabilization units are 24-hour crisis units. You see some pictures here across the county, and it's a really transformative thing for the way that crisis care is delivered for our region and for our state as a whole. And one of the things here is we need to think about how these are accessible to older adults, both cognitively, physically, and culturally. When you call, are there the translation services that you need? When you have someone come, do they have the vans and that are equipped for ADA and mobility needs for older adults? Same with the crisis stabilization units. Are they appropriate for older adults in those care settings? That's a really exciting thing in terms of crisis care and what's happening in behavioral health. Okay, I'm going to call out something it's really exciting. Many of you have probably heard about CALA and the Department of Healthcare Services investment in really trying to care for the whole person. Big investments in terms of additional supports that are available under Medi-Cal. So for those dual eligible patients, Integrated Health Partners, IHP, is our clinically integrated network with 9 of our health centers that we work with. And they're doing some really great work to embed behavioral health care into their care coordination for all of the physical behavioral health needs to help folks get the real support that they need. So IHP has a social care manager program that takes that approach by integrating it. Federally qualified health centers from day one have been integrating behavioral health and primary care into the same physical location into the work that they do. They're doing behavioral health navigation. So they're working with care managers and community health workers to bridge those gaps in care by coordinating a referral. How many of you have spent time on the phone trying to get a referral, trying to get seen by somebody else? So it's facilitating those warm handoffs. So there's clear communication between providers. You have help with your appointment scheduling, with transportation, and then continuing to follow up. Through enhanced care management, or ECM, IHP is connecting community-based services that are newly covered under Medi-Cal, like home delivered meals, um, IHSS, housing navigation, and social engagement programs. So trying to get all of those benefits that someone's eligible for into their hands and have them be integrated and coordinated. And I think that's one of the things when you have a care team, when you're seeing a behavioral health provider, a primary care physician, a specialist, et cetera. So what does coordination look like? Once you have access and you're in the door and you're being seen, is it coordinated care that is actually appropriate for what someone needs, particularly as an older adult, as those care needs may increase, as you're managing multiple medications, and things like that. So um, this care coordination, the investment that the state's been doing in CalAIM, and looking at older adults in particular, I think is very exciting. And even though we are facing extreme budget uncertainty because of some of the policies through HR1 and the Big Beautiful Bill on Medi-Cal, I'm really encouraged that our state is going to choose to continue to invest in the care for its Medicare, Medi-Cal patients and to integrate, do care coordination, ensure that the whole person is actually cared for. So you're like, okay, but you're talking about behavioral health. Didn't I vote for something in 2024? Yes, you did. Voters passed Proposition 1 in 2024 to really transform. It's called behavioral health transformation for a reason, because it is transforming our behavioral health system in California. There's opportunities for infrastructure investment through a bond through Prop 1. And then there's also a huge shift in the Mental Health Services Act, which was called Prop 63 or the millionaire's tax, um, lots of different names, but the Mental Health Services Act um, was designed as kind of a whatever it takes model to ensure that we have investment in behavioral health and mental health. When voters passed Prop 1, they transitioned the Mental Health Services Act into the Behavioral Health Services Act. And by transforming it into the Behavioral Health Services Act, it added in substance use disorder, it added in an emphasis on housing, and it added in more evidence-based practices. So really trying to say what works and what has evidence that it works, whether it be through peer-reviewed research or through community-defined practices. And we're going to invest in those practices to say we want to do what works and we want to double down on that investment for counties across the entire state. And what we can see going forward, and you're like, okay, cool, all of this is transformative. You're really excited. I am very excited. Um, it's also a scary moment. There's a lot of change, and it's going to be hard to get it right. And that's where all of you come in as stakeholders. By attending this call, you clearly are interested at some point of behavioral health for older adults. And so I call on you to get involved in the stakeholder engagement process with the state and with your county. So if you're in San Diego County, feel free to follow up. I'll tap you into the Behavioral Health Advisory Board and with BHS, but they're doing integrated planning. So, like we talk about in the delivery system care model, like in your doctor's office, integrating behavioral health and primary care, they're doing that at the larger level, the planning process to say we need to integrate plans. We need to say that what are the investments in the community health needs across the behavioral health system, across the hospital system, across the managed care delivery system, and really integrating all of those plans so that it makes sense together. And there are opportunities along the way for stakeholder engagement, for you to elevate the needs of older adults, to elevate the unique concerns around all of the social factors, the societal factors, insurance factors, all of you, if you're not involved, called today. Pull up here, cost or free psychology treatment, but don't want to go through insurance due to privacy and sharing of information with all medical providers. Okay. Concerns about privacy, concerns about treatment for health insurance. And we're seeing that across the board right now with concerns about immigration and where can I go to turn to get care, and that's very real. I'd say if somebody does not have insurance, they can go. There are some free clinics. You can go if you're uninsured to a federally qualified health center, and they will serve anybody regardless of their insurance type or help you enroll in insurance and help you figure out how to navigate some of those concerns about data sharing and eligibility. So I encourage you to reach out to federally qualified health center or a clinic in your region. And I want to throw out one other big kind of like access number is 211. So if you need help with social services, you need help getting connected there, 211 is a resource for the region, but for particularly medical care and behavioral health care, federally qualified health centers.
The next question, Amanda, my internet was freezing. Sorry, I didn't I was going to rephrase all these to get back to you. But the next
Go
question I
ahead.
think is really important. The person is kind of building on their previous question, but asking about or talking about the challenge that medical professionals, when they see a diagnosis in someone's chart, sometimes there is a stigma that's actually coming from healthcare professionals. Can you talk a little bit about, if you have any knowledge on this, I'm sure you do, or some insight, but what is going on in the world of healthcare to help decrease stigma and make patients feel like they can come to their providers when they have behavioral health issues?
Yeah, that's like I said, stigma, there's a lot of different versions of it. There's stigma towards yourself, your internalized stigma. There's stigma from others. There's societal stigma. And that question about having stigma from the provider themselves, that is your kind of trusted provider. Um, I think one of the things, and I say this as like a social worker advocate person, is advocating for yourself and being sure that when you are talking to your provider that you have an agenda as a recommendation that I have is what is your agenda for your appointment, and really helping the provider focus on the agenda that you need help with. Um, so that you can focus on those things and not get distracted by another diagnosis. I'll say that that's one thing that you can do as an individual is like as advocate for yourself in terms of where you want to focus to reduce some of that stigma. But secondly, we need to train our providers. And I think that that's been a huge movement is improving that culturally competent um, training for geriatrics that doesn't really exist in terms of geriatrics. It's increasing. It's growing. Talk about SDSU's program for geriatrics. There's a lot of interest as we see the population aging, but it's training for the providers too to understand that just because somebody has a diagnosis on their record doesn't mean that every appointment needs to be about that diagnosis if you have another concern that you're coming in with.
And then, yeah, I just want to build on that. I think that, like you said before, change takes time, and there's a lot of things coming through the system. I'm just thinking back to when I first started in healthcare, and people were, this was like a decade ago, starting to focus on social determinants of health and like doing those screening questions. And now it's become really common practice, and it's something that I think healthcare providers are really comfortable talking. Well, where I used to work, very comfortable talking about and bringing up, and you'll hear it from multiple providers, and it's a really big focus. And I
Mm.
think models like the PACE program, like you said, are very promising because when providers can start to look at the person holistically and it's not just one diagnosis and there's someone on their team that can help address behavioral health issues when it comes up, it's very scary for providers, when scary if you don't have resources when something comes up that you don't know how to address. So I think models like the PACE are awesome because it does give them a resource and somewhere they can send people to get the help they need and the resources.
Yeah, and
Okay.
having that integrated care where you have a care team, I think it is really unique. And I'll say, one of the benefits during COVID and adding in more telehealth and the technology that we have is having care consults with experts. We said 1,800 geriatric psychiatrists in the entire United States. So not necessarily needing that expert in the actual four walls of the health center or your clinic, but to be able to call on a resource as a specialty provider or something like that, and using the benefits of telehealth for things like that. So um, there are things that are happening, and I think as we do more integration in behavioral health and primary care, you actually see more of the care team that can address a lot of the different questions and needs of the patient.
Thank you. And thank you for that attendee to ask those important questions. I think that those are just really important things that come up for a lot of people. Nadine had a great question here. And I did some side research if you don't know the answer. So do you know that if people who are involved in the PACE program, if they are still able to receive in-home supports and services?
They're not eligible for IHSS if they're in the PACE program. The PACE program is able to provide similar um, in-home care that IHSS would, but it's not you cannot be enrolled in both.
Okay. I'm checking the chat here. Are there any other questions for Amanda today? Someone said appointments take too long to make, only 20 minutes for an appointment time. Must have your questions listed in advance. Referrals take a while to make as well. Boy, that speaks to our fragmented system, huh? The
Yeah.
challenges. Yes, thank you, Lee.
Good point, Lee. That's it. Have an agenda, have your questions listed in advance. That time goes by really quickly. And I think the other thing that I've heard folks really utilizing too is a lot of the patient portals and patient and messaging systems to help communicate your needs in advance and in follow up to your providers so that you can have documentation of that. I know some folks do, like medical journals where you take notes and you have all of your notes for your appointment in one place. That can help with also with caregivers and loved ones who might be supporting you in navigating this complicated system. Because I got to tell you, sometimes it takes a team to navigate some of these systems, and we've got care coordinators and we've got CHWs. But as you can kind of take that self determination to say, I'm gonna come in and have your questions listed in advance. So, Lee, it's a really great point.
Okay. Amanda, if people wanted to reach out to you, where could they connect with you?
I will drop my email in the chat, and I am happy to take questions and follow up.
All right. Thank you so much, Amanda. It was wonderful to have you here with us today. I want to invite everybody to please log into our seal.sdsu.edu website and check out our next upcoming webinars. We have a very exciting one coming in September about intergenerational connection and a new framework that a group of researchers looked at. In October, we are going to be doing a 4-part webinar series that talks about the age-friendly universities across the nation. And I just got someone who reached out from Canada, so it'll be across the world now. And then in November, we are going to be doing a special series about technology that helps to support caregivers. And all of those things are going to be available on our website for signing up. So please go there to see the webinars that are coming up. And then in addition to that, you'll see Amanda's up there in just a few days. Thank you, everybody.
Thanks, everyone.